Good morning, everyone, and welcome. We're so glad that you could join us today. I want to extend a warm welcome to each one of you as we kick off this session. Today, we are excited to bring you another installment in our Hospital System Addictions Care Community of Practice series. The focus of this session, as you can see on the slide, is Care After Crisis, Alternatives After ED Discharge. But before we dive into the content, I would like to acknowledge that this COP is coordinated by our planning committee, supported by various partners who are committed to advancing these programs. And we're thrilled to have you all here with us to listen to this COP. Please note that this session is being recorded, and to help maintain the privacy of all participants, we kindly ask that you keep your microphone muted unless you're speaking. And if you prefer to remain anonymous, feel free to turn off your video. However, you're more than welcome to keep it on. Let's cover a few housekeeping items before we begin. So let's move on here to our next slide on the usage of Zoom here. So if we look here at the slide that we have in front of us, if we have a few issues with your audio, you can choose a different microphone or speaker arrangement in case you can't hear us or you cannot participate with your mic. Please remember that we're recording the meeting, so keep your microphone off unless you're speaking. And also, we highly encourage to use the Zoom engagement tools. As you see at the bottom bar there of the meeting, we have the reactions button that you can raise hand and react with different emojis and emoticons there to the content that is being presented. With that being said, we want to hand it over to Dan, who will be taking over. And Dan, you have all our attention.
That is an exciting thing, and I appreciate that. Thank you so much. The Hospital Systems Addiction Care Community Practice is funded by the New Hampshire Department of Health and Human Services, Bureau of Drug and Alcohol Services. They provide funding to Growth Partners and the Foundation for Healthy Communities to conduct this to improve the care of persons with substance use disorder in the New Hampshire healthcare system. As Nancy Fennell and I have made our rounds on an initiative in the Hospital Association to improve OUD care, the question that comes up continually from hospitals, has come up continually from other hospitals over the 8-year arc of this grant, is, but what about when they're discharged from the emergency department? What happens then? Today, we brought together 3 organizations. Glad to welcome you all to answer that question. And the objectives of this meeting are to learn how to make appropriate connections, learn some tools for helping individuals to engage treatment after their discharge, and perhaps most importantly, for you to meet the people who are actually doing this work and to ask questions and to begin to form those relationships, that partnerships, and that awareness. With that said, we're going to jump into some introductions, some very quick introductions. And I will start with Jill Fitzgerald. And after that, John Peters, and after that, Zach Jensen. I'll just ask you to go in that order, and then we'll jump into the presentations and have about 15 minutes apiece for those. Thank you. Jill, you're up.
Thanks, Dan. Hi, everyone. My name is Jill Fitzgerald. I am the Senior Vice President of Clinical Operations for Confidant Health. Excited to be here today to be speaking with you all about what we're doing at Confidant and how we can potentially work together. A little bit about me. I am an LICSW by training. I have been in the field for over 20 years, both as a provider and as an administrator and operations leader. And I've been with Confidant just about 3 years now. Prior to this role, I worked in New Hampshire with Easter Seals for almost 10 years, overseeing their clinical services across New Hampshire and Maine. So I'm a New Hampshire local. I live here, grew up here, and excited to be here with you all today.
Thank you. John, you're next.
I'm John. I'm the medical director of Better Life Partners, New Hampshire. I spent the first part of my career as a hospitalist and primarily as a nocturnist. I love putting out fires and hanging out with my buddies in the ER. And And I got into this, I sort of made the transition to full-time addiction medicine when I realized just how many people were in the hospital because of that, or in the ER, and were coming back and coming back and coming back. You know, I went from being the unofficial addiction medicine consult service to being more of a real one. So I work with Better Life Partners, and we do a lot of stuff, but our foundation is opioid use disorder, and I'm just so excited to be part of the solution, and hopefully help you guys who are really on the front lines of it, making those connections.
Thanks so much, John. Zach, will go to you.
Wonderful. My name is Zach Jensen. I'm with Aspire 365. I'm one of our founders. My name is showing up as Steve Jensen, who's my father. He's another one of our founders, along with my brother. Family-run organization. So you guys are blessed with the smarter, better-looking Jensen of the crew. So you're welcome. Yeah, Aspire 365. We've been around for about 7 years now. We operate in 13 states. We started specifically in addiction medicine, and have expanded to primary mental health as well. We work with adolescents and adults, and I'll get into that when it's my turn. Glad to be with you guys.
Thank you very much. With that, we'll move forward in the presentation. Danny's hands are on the PowerPoint, and Jill, we'll start with you and bring your presentation up.
Sounds great. Thank you. So happy to be sharing a little bit more about Confidant Health and how we partner with hospitals across the 5 states that we are currently serving. And so you can go to the next slide. I think everybody in this room knows that, you know, we're all struggling to meet the crisis with mental health and substance use, and that a lot of people that are experiencing these types of needs are not getting access to the care that they need. Many of them are then showing up in the ER, and you know, providers across the state are having a difficult time in getting them connected to treatment that is meaningful to them. Next slide, please. So, you know, what does this result in? This results in people not getting access to care, results in really, you know, unfortunate outcomes for both the system and for the people in need of care. So that's why we're here at Confidant, really to focus on solution and partnering with other community partners who really are mission driven in this way as well. We also know that these particular clients who are struggling with addiction and mental health needs have overall higher medical spend. And so we're really trying to focus on how do we get access to care for people that need it by improving their overall quality of life and reducing their overall medical spend across the board. So that's sort of why we're here. We're here to partner to provide that behavioral health care support and make sure that that's available to patients in a timely and responsive fashion that sort of puts them in the driver's seat of their journey and really designing what recovery looks like for them. So Confidant Health is a distributed quality network. We're both an AI-powered platform and an integrated provider network. So we have providers that work for Confidant, both in full-time and 1099 capacity, and we're delivering behavioral health services across the 5 states that we're in, using our own platform to do that. When we partner with hospitals, health systems, health plans, we are there to partner to provide those behavioral health services. We're offering improved accountability, we're sharing outcomes with our partners, and we're lowering clinical costs across the board. So we're really sort of that bolt-on solution for health systems, hospitals, and other partners to really make sure that patients that they're seeing that need access to behavioral health care are getting it and are matched with the right provider at the right time. And part of how we do that is, and this picture here is a client of ours actually got this in a different state, not in New Hampshire, but when they went to the ER, this is the referral that they were given. It was on a Post-it, they were given phone numbers and sent on their way. And so we really want to change how that works, because we know that that is going to result in people not accessing the care that they need. So when we partner with somebody, we engage in proactive outreach, reaching out to that member, getting them connected with an appointment, and then delivering behavioral health outcomes that are really sort of in line with what the member is looking for in terms of their recovery journey. We have a multidisciplinary care team. So we have nurse practitioners, MDs, therapists, recovery coaches with lived experience, and we accept most major insurance plans in New Hampshire, including all 3 MCOs. And the types of services we provide, sort of full service behavioral health clinic. We provide psych evals, psych med management, medication for addiction treatment, evidence-based therapy, groups, coaching. So we're really able to wrap around the person and determine what type of provider is going to be the best fit for them, and sort of get them connected with care that is going to work for them. We don't have a wait list for referrals at this time. And we will support if we're not a fit, if we're serving people in the virtual setting. So if they cannot be served in the virtual setting, we will work with other community partners to get them connected. Currently, our population that we're serving, we serve adults, so 18 plus, and about 50% of the people that we're serving are Medicaid population. Many of these individuals struggle with the social determinants of health, as you can see here. And so our team really focuses on breaking down those barriers and getting them connected to community resources, because we know that that will support further engagement in the treatment that they're looking for. So how it works is someone gets referred to us, we engage them with the right provider, and then our platform that we designed supports the providers in delivering the right care at the right time. So it's going through standardized assessments, it's validating data, it's recommending treatment interventions to the provider based on these assessments, and it's helping to build personalized treatment plans. So it's really supporting providers to deliver care and interventions based on symptoms, diagnosis that is being reported in these sessions. In terms of referral pathways with partners, we will take referrals however it works for the partner. So we're very flexible in that way. We take them by fax, we take them by email, we take them by website inquiry, whatever is going to work with the partner. We usually work that out in the beginning, and then we also can meet with the partner on some sort of regular cadence to check in, see how that's going, and really sort of make sure that that referral flow is working in the way we want it to. One of the new exciting things that we've been working on is a confidant kiosk, which is what you see here in this image. So, and this is specifically for EDs. So we're currently launching this, in the process of launching this in one ED in New Hampshire, and really trying to target those seamless referrals from ED providers. So basically, ED providers can use this kiosk to support patients who are in the ED booking their next confidant appointment before they leave the ED. And so it's bridging that access to timely care for treatment that's initiated in the ED as well. So really allowing the patient to be a part of this process and supporting providers to know, okay, if I start this person on a medication in the ED, they have an appointment within 3 days with confidant to follow through with that treatment. So that we're really excited about this. Happy to talk about this with anyone else who might have interest, but excited to launch this in New Hampshire. This will be the first time we'll be using a kiosk so far. So we're really excited. Some of the benefits, just in terms of a working relationship with partners, is we really want to share outcomes. So we really want to show partners, hey, this is what we're seeing at the aggregate level. People are reporting improved scores on the PHQ-9, on the GAD-7. They're reducing the ER visits. We're engaging in those warm handoffs and continuing that conversation. So we're really excited about being able to partner with systems to be able to share that information in real time. And we track a lot of data. We're very focused on high quality care. So we're eager to talk with partners about what data would be meaningful to them to share and how we can help to sort of define that in a working relationship. But these are just some of the assessments that we do at intake and on a monthly basis and are monitoring progress. And what's great about that is this is visible to the provider in the platform as well. So they're able to see this and augment treatment based on the results that they're seeing. So I wanted to share just a few outcomes that we've had to date. This is one partnership that we have with a Medicaid MCO, and we've had an 84% engagement rate with members that have come to us through this partnership. 88% of them have had a reduction in the PHQ-9, 94% in the GAD-7. We've had 100% follow-up after hospitalization within 7 days, and 80% of the people that we're serving for OUD, MAT in the virtual setting continue to be engaged. And this is a quote from one of our partners that we're currently working with, but we're really, we take a lot of pride in developing these partnerships to make sure that we're meeting service gaps that people are seeing. And so, what we hear a lot from partners is that we're seeing a lot of people come into the ED for behavioral health needs that could be managed in other settings, but there is just no access to care. And so we're really passionate about partnering with people to be able to meet that service gap and to be able to improve outcomes for people that are struggling with addiction and mental health. And that's that. So happy, I know we have questions later on, but I'm happy to answer any, and also happy to put my email in the chat as well for anybody that might want to reach out directly.
Jill, thank you so much. A lot of information, and you made it a few minutes under your allotted time. John, we'll turn to you now and advance into your slides.
I'll take those few minutes. Hey, I'm John. So as we said, you can go to the next slide. I'm the medical director of Better Life Partners. This is going to be like just way too much information in such a short period of time. So I'm going to try not to overload you, but I'm so excited about this in this community because like when I started at Better Life, one of the biggest things I wanted, I was like, I want to have a curbside service for ERs and hospitals because that's really where my passion is. So I'm so excited about it. Forgive me if I get like a little over the top. Next 10 minutes, we'll do some introductions. We'll talk about Better Life. We will watch this cool video in just a sec. And I want to share with you a rapid induction method. It's just a tool to use in the ERs because I know inductions can be stressful. If we can, this is a video, Danny. I'm not sure if we can play it or not. This is from the Beauty of Data. It's this cool org that makes turns important data into something a little more manageable. It's only a minute long. If you can't read it, like if you make your screen big and can't read it, the pink is prescription opioids, the red is fentanyl, and the blue is methamphetamine. Are you able to play that, Danny?
No, it doesn't seem to be loaded here as a video. It's just a screenshot. Yeah.
Bummer. Okay. Well, whatever. We can play it later. Anyway, it's a really cool video. I'll share it on my website. It's weekintheimpossible.com. But if you feel like checking it out. Anyway, you can go to the next slide then. Oh, so sad. And the next one. That's us. And the next one. I think these switched orders. So Better Life Partners, this is our mission statement. We provide whatever it takes to help people heal from addiction, wherever, whenever, and find belonging, love, and purpose. And we take that really seriously. We have a lot of community partners. We really believe this is not just an us thing. It's not a patient-doctor thing. It's a whole community thing. You can go to the next slide. So whatever, whenever, wherever. So this is the wherever part. So this is where we treat people kind of everywhere in New Hampshire. We started in New Hampshire. This is, really where our passion is. I mean, our passion is everywhere. We're all in New England now. Well, I think we're in North Carolina now. We just keep spreading out. And our goal is to provide access everywhere. We're primarily virtual. We do in-person stuff as well. But our goal is access. So next slide. So here's our care model. It's a hybrid, it's hybrid care for people with SUD. So that's primarily opioid use disorder. Let's face it, that's what people have. Alcohol use disorder, polysubstance use disorders. We're going to have a dedicated stim use disorder thing in the next few months. That hasn't rolled out yet. We still treat it, but it's not, one of these dialed in programs quite yet. We have all the things, the recovery coaches, we've got counselors, group counseling, individual counseling. One of my favorite things we do is responsive care or virtual responsive care, VRC. This is people who are coming from prison who need bridge scripts. This is people who have an abscess or like a dental infection, and they're going to go to the ER. They're going to need antibiotics to get them through whatever the thing is. They can come to us. To be honest with you, 95% of it is unmet psych needs, and that's why we've been building out a pretty great psych team. So we do psych care as well. We're in person in Manchester at the 1269 Cafe. If anyone's familiar with it, it's the warming shelter in Manchester. And we're there 9 to 5, Monday through Friday. We also are at partner sites throughout the state. So we have 8 partner sites we go to, some of them weekly, some of them monthly. And I really want to get a van. So if anyone has a van that we could have like a mobile health unit, let's definitely do that. But yeah, our goal is partnerships. It's creating access and bringing people together who are already working on this instead of working in separate silos. So access, we accept everyone. So all adults, all locations, all payers. We don't discriminate against anyone. We've never turned anyone away for inability to pay. That's basically I wish I could say something cool about it. That's basically it. Talking about the warm handoff. So this is 2016. This is the Olympics. This woman has just sprinted her ass off around this track. This is the culmination of her career, and she just has to hand off this stupid baton, and they're going to win, and they fumble it, and that sucks. And being in the ER and doing all this work, and then for aftercare, so many of us for so many years we have this crappy photocopied paper with AA meetings on it. And if you've worked in, with care, any kind of care coordination, social work in the ER, you've seen this paper. And we say, here you go. This is your aftercare. These are phone numbers for AA meetings. Enjoy. We want to change that. And by the way, I love that last presentation, the iPad thing in the ER. I think it's a great idea. We offered that. A lot of people don't take it, but I think it's awesome. So next slide. So our goal is to never miss a handoff. We do a lot of stuff. We even do some primary care. It's crazy. But what we really do, and what our real goal is, our mission is never to miss that handoff, to always answer the phone, to always be there. So we do same day appointments. We're open 8 to 8 Monday through Friday. We've got some Saturday hours and hopefully Sunday hours soon. I actually really want to get 24/7 access. We're not quite there yet. But we basically start out, we're getting people in within 3 weeks. That's better than most. And we said, that's not enough. We got to do it within 3 days. So that was our goal for a while. And we're like, you know what? We can't do that. We got to do same day appointments for everyone. Great. And we finally got to the point where we said, like, in the age of fentanyl, you go from being high to in withdrawal in such a short amount of time. Even if we give you an appointment 3 hours away, from now, it's just not enough. You got to take advantage of that moment of ambivalence. And so we have a walk-in clinic now, and most of the time, if you're, calling business hours, you get a same phone call appointment. So if you call from the ER during the day, we answer, we transfer you to a provider, and we do an intake then. And they have buprenorphine within 3 hours, and it's great. And that's important, right? We do all the counseling. They have, later that week, they have this like hour-long clinical assessment with a counselor. They get down and dirty with it. But when their lives are chaotic, you can't start there. That's just such a hard place to start, whether it's withdrawal, whether it's just the chaos of use. We really believe in this medication first model because it allows all the rest to happen. It sort of eliminates a lot of that chaos. So most of the time we can just get people in. If you call nights and weekends, we'll get them in the next day every time. Assuming, obviously if it's, it's Saturday night, we're not open Sunday, it would be Monday morning we would call. So you can go to the next slide. I wanted to talk about inductions. I know we're kind of talking about the warm handoff, but I think this is integrally related. I talked to a lot of ER docs, both when I was a nocturnist and also just now. I talked to hospitals, ER doc. The inductions freak people out, and it's always, and it's mostly that precipitated withdrawal feeling. You don't want that to happen. That's something you don't want to deal with, and it's always interesting to me because like ER docs are freaking rock stars. They're like, I'm like, going down an assembly line of intubation, we're pushing calcium channel blockers, IV. Oh, we're stopping people's hearts and just kind of trusting that they're going to restart again on their own. It's like a computer. Let's just unplug it and plug it back in again, see if that works. When we're treating SVT. But I think there's so much, we've been told so much that's kind of, some of it's stigma, some of it's half truths about these things that we freak out about inductions. And I really want to be able to empower people to do this a little more aggressively than a lot of times we're comfortable with. So you can go to the next slide. So there are lots of ways to do induction. We could talk about this for hours. There's like a concurrent use microinduction. There are high dose inductions. There are low dose. There's that standard thing where you let them just, wait it out, do a whole detox, and then start. Any of them can be right for some people. I think the easiest for us, and by far the easiest for our patients, is a rapid microinduction. And the point is you don't have to wait for severe withdrawal, because then, between mild withdrawal and severe withdrawal, you're going to have 90% of people who are like, no, I am not dealing with this. Next slide. So in a nutshell, the rapid microinduction goes like this. You wait 8 to 12 hours. This is common, right? Somebody comes in, they're feeling like crap. They're in the ER getting their workup. They've got an echo, they've got endocarditis. They got to stay for IV antibiotics, and you got to, do that whole show. Right around the time that infusion is starting, they are ready to leave. This is when they're going to use the bathroom. This is when they're trying to get out of here. This is when they're leaving AMA. And this conveniently is the time you can start a rapid microinduction. So the key here is you start low, super, super low, and you slowly push off the fentanyl from those receptors as you increase the buprenorphine. And then if at any point you go into this severe precipitated withdrawal, you slam the rest down. You give them all 24 milligrams right away. And that's what gets them out. A lot of people, it's like they start giving them and they start doing this induction. And then they're like, oh no, they're in withdrawal, I have to stop. No. That's when you go further. And honestly, I think 32 milligrams is a super safe, super easy. I wouldn't even think twice about doing that for somebody for an induction. So you can go to the next slide. And this is one of my favorite graphs. I show this to a lot of patients. I actually have this as a Zoom background. I do the weatherman thing and, show patients what's going on here. But this is the opioid binding curve for buprenorphine. And if you look at it, like, you're not hitting that many more opioids between 24 milligrams and 32 milligrams. You're not really risking a lot more respiratory depression. I heard the other day there are places in Japan doing like 96 milligrams at a time because they don't even want to deal with it. They just want to like get you in and get you out. I probably wouldn't go that high. But from this standpoint, it's pretty safe. They're not going to stop breathing. But what you are going to do is increase the substrate, increase the concentration, and that really helps push that bupe onto those molecules and get them out of withdrawal. So next slide. I'm not going to go nuts with this one. This is a little more granular about how we do it. You start every hour. You do 0.5 milligram to 1 milligram for the first 5 hours. If they make it that far, you give them 16 after, so that gets them up to 24. And then in 6 hours, if they're still in with any kind of withdrawal, give them another 8. Totally fine. And then you just keep going with that dose. So if it is 2 a.m, if you can't get a hold of us, because we're happy to do curbsides, we're even happy to just take over prescribing and prescribe right there. You don't have to do it. But if you're on your own, like this is a super easy algorithm to use. And again, the point is that at any point, let's say you're on hour 3 or 4, and they go from I'm feeling crappy to I'm having explosive diarrhea, you say, great, give them the rest of it. So anyway, so I just want to do that to empower you. Whoever, I'm so excited to hear all these other folks who are doing some cool work and providing more access. Whoever you go with, you can use this as a starting place. So you're not just worried about it. Next slide. Yeah, we did that. Next slide after that. And this is how to connect. This is it. Just call. So we have one line that comes right to us. There's no little robots that talk to you unless we have really high call volumes, or you're calling after hours and you get a call center. But just call us and we transfer you right over. Most of the time, so if you want a consult, call curbside, ask to talk to a provider. That's totally fine. For patients, though, if you have somebody you want to get in touch or you want a warm handoff, in place of that photocopied AA sheet, have them on their phone, call us. We will literally connect them directly, talk to them, and we can probably do an induction from the ER. It's really that simple. And so, I don't want you to be intimidated. That's really the only number you need. And you can use, I found this nifty QR code with a T-Rex on it. You can also do that if it's easier. And you can go to the next slide. And reach out. I'm on vacation now, so I won't get your stuff for another few days. But the top one, that's my email address at Better Life. So anything, referrals, Better Life, SUD related. If you just have questions, we can't be a hotline because we're not, 24/7, but we can be a warm line for you. I'll get back to you, within a day or two if you just have questions. And then if you do want to talk about education, or training, we are starting this nonprofit. So feel free to reach out at weekintheimpossible@gmail.com. And if you want the video, it's going to be at.
I was just going to ask you to put it in the chat if you don't mind, John.
It's I'm not even sure if this will work. It's www.weekintheimpossible.com. I am not a web designer, so this is like a holding page. www.weekintheimpossible. It's I've seen that video is one I've watched easily 100 times and probably more. It's a minute long. I really encourage you to check it out because it really highlights where we're at. And when we say this is like an opioid crisis, it's a crisis. It's one of these pieces of data when you're looking at numbers and zeros and commas, it doesn't quite register. And then when you see it all put together, and this place, the Beauty of Data, has done a great job with it. It just reminds you where we're at and why it's important and why you do what you do. So anyway, I think y'all are rock stars. Thank you for doing what you do, and feel free to reach out.
John, thank you so much. And Zach, we will turn to you now.
Jill, John, excellent job, you guys. Fascinating what both of you do. Really appreciate the information. We'll have to collaborate after this because there's a number of things I think we can do together. So as I mentioned before, I'm with Aspire 365. We've been around for a few years now. We've been in New Hampshire for 4 years. As I stated, we began working primarily with substance use disorders, and have since expanded into the mental health realm. We work with a broad range of not only behavioral health conditions but ages. We work with adolescents, 12 years old on up. If you want to skip to the next slide, I think these cursory couple of slides we can breeze through because Jill and John did such a good job. 7 years ago when we started Aspire, we looked at some of the behavioral health system limitations and it really consolidated a really strong clinical team. I have no clinical background, can't hide it. You guys would be able to tell instantly. But we did consolidate a very, very strong team nationally to design an infrastructure to address some of these shortfalls that exist in the behavioral health system. One major area of concern was that most care delivery was short-term in nature, expensive, low outcomes, and then high barriers to access. At Reach were a lot of those limitations. We got a lot of rural communities around the country. I'm out of Salt Lake, Utah, and in Utah we have a lot of rural communities. Every state does. New Hampshire does. We've been in and out of the all through the state, and there's plenty of rural going around. And a lot of those rural communities struggle with access to care, quality behavioral health care, or any behavioral health care for that matter. And so what we set out to do was address those kind of four areas. We wanted to design programming or structure programming that was long-term in nature or chronic, to address the chronic condition that is substance use and mental health. We wanted to make sure it was accessible and financially accessible, that the care was effective, and that it was reachable or accessible geographically in the locations that we're at. As I mentioned, we're in 13 states. In all of the states that we're in, we cover those states corner to corner, and deliver care in all the rural and urban communities in which we're in. The way that we address these shortfalls in the behavioral health system, and Jill and John are doing a fabulous job working to address these as well. We deliver long-term care in the home, and we do that through a combination of telemedicine and in-person visits to the residents. So if we could go ahead to the next slide. The way our care is delivered, as I said, we are designed or structured programming. And what we mean by that is we've collected data over the last 7 years, and our programming continues to adapt and change based on conditions and needs and comorbidities. But our programming is delivered through a standard 6-person multidisciplinary team. So that includes, if we're looking at a patient life cycle in the program, we get a referral, a patient is immediately assigned after an admission screening and a psychiatric eval, they are assigned a 6-person team. And that 6-person team includes a psychiatrist, a nurse, an individual therapist, a family therapist, a case manager, and a peer recovery or a life coach. We can layer in, we have dietitians on staff that work with individuals with eating disorders or those that could use dietary improvement. We have family support services that have expanded, that work directly with, mostly with our adolescent parents, and they work with them independent of the patient for psychoeducation and support the family and parents directly. We have groups and educational courses and all the above, but the initial 6-person team is who works with the patient one-on-one for all of our patients. We work with our patients a minimum of 12 months. So our programming is 12 plus months. It's long-term in nature. We are a heavy clinical program. So for most of our conditions and comorbidities, patients will have between 140 and 160 individual visits in a calendar year. So it's a lot of direct visitation. They have access to unlimited groups and educational courses. Our patients have access to their case manager, as well as those group sessions and educational courses for life, even after they've exited full programming with Aspire. We do, as I mentioned, work with our full adolescent population, our adult population, and our programming is designed for each. Access to the team is pretty immediate. So we do not have a wait list in any of our 13 locations. We design or we onboard providers and add bandwidth in advance of demand and our initiatives with our insurance partners. You can see our national averages here for layering in our services. The reason we stage in the services, and you kind of see family therapy lagging in at 30 days, is so that we don't overwhelm clients. We're layering in a lot of services up front. Our programming is designed to operate around a patient schedule. So we want patients working, we want parents parenting, we want kids in school, we want them living their lives and engaging with their environment while they get services. So we wrap our services around their availability and around their schedule. So this includes evening and weekend appointments, mornings, lunch appointments. And so in order to not overwhelm clients, we stage in services and introduce their team members incrementally. We do have immediate onboardings and admission screens. So as we get referrals, patients, members have access to admission screens same day. They'll meet their case manager same day or next day. And they'll have their initial nurse and psychiatric evaluation. Nationally, we're running at like 62 hours on average to get patients with their psychiatrist. Some of that lag time has to do with when a patient's discharging from the hospital. Can we get access to them while they're still in the hospital and process that admission before they discharge, or do we have to wait? And so you can see we do get services in quickly. We don't want a significant space. We love a soft landing for patients so they have a team in place as they're being discharged from an inpatient setting. Patients can self-refer. They can be referred for primary care from the hospital. We do work exclusively in network. So the reason we do that is we're talking about affordability. You're looking at 140 to 160 individual sessions with clinical and medical professionals. It can be very, very expensive. We have a unique contracting structure with our partners. Everything is in a bundle. Typically what you'll see, a patient will see that we are covered services for, or that has insurance that we take. They will have one monthly copay for all the services that they receive. So they can have 25 individual visits plus 10 groups in a month. And it'll be a single monthly copay that aligns with their primary care copay. So it's like $20 a month, right? Outside of their deductible and out of pocket. So the insurance we work with in New Hampshire, as we're expanding, we're adding more and more. We're national with Humana. We have Anthem, Blue Cross Blue Shield, and we're continuing to add others. Our program is very close at Cigna. But that unique contracting structure makes things a little bit slower to add new contracts. And so we're working on that feverishly. Referrals to us are pretty straightforward: fax, phone, email. We can be reached. We run broad hours with our teams, and our teams are very, very responsive. We will know within a few hours whether or not a patient is an appropriate fit for our care. A lot of admission screens take place in the hospital setting, so that if we can connect with the patient and or their parents and process that screen, we can let you know if they're a good fit. I will say 90% of the individuals who are referred to us from a hospital setting who have our insurance are a good fit. They certainly meet acuity for our care. We are considered PHP through OP in level of care due to our intensity of services. However, we are outpatient services. So when we're dealing with active suicidal ideation, active homicidal ideation, some of those cases will need to be referred inpatient. Lastly, the last thing I'll talk about is the next slide. We do have a unique preventive screening tool that's available to any members of the insurances we cover. It's a fully covered service, just like your annual physical checkup or dental checkup. This screening tool is available to any of them. We use this pretty broadly in most of our areas, and it's an annual psychiatric screening exam. The only reason I bring this up in this setting is if you have family members, parents, loved ones, or the patient themselves that would benefit from a mental health checkup, right? They come in, they're struggling, they have questions, concerns that might not easily be addressed in the hospital setting, they can be referred to this. We supply QR codes, links. They can schedule immediately. They process a self-administered screen, which takes about 5 minutes, and then they have a 15 to 20-minute consultation with one of our behavioral health technicians, and they can get their questions answered. That gives us a preliminary diagnosis, an ID on the patient needs. And if there are needs there, they can be wrapped into services immediately. So would love to supply any of our contact information to the team, whatever, however is the best way to do that. But we love our New England community. Love coming out to see you guys, and we'll continue to expand there and provide services. And so would love to connect further with any and everybody on here. But thank you for giving me the time.
Thank you very much, Zach. That concludes our 3 presentations. So I'd now like to, we're a few minutes ahead of schedule, open the floor to any questions that anybody has. You can either do the formal thing of raising your hand or simply just unmute and ask. We're a small group.
Dan, I had a question.
Yes.
What are our 3 speakers? How are they managing the co-polysubstance use of not steroids, of amphetamines and opioids, the up-down effect, we call it, or they call it. How are we managing that population?
Yeah, it's a great question. I don't mean to jump the line. I almost had a slide on this, but obviously it was way too packed anyway. So it's huge, right? So half of opioid overdoses right now have methamphetamines in them. It's so common, and it's common enough. So it used to be, okay, there was some heroin out there was some coke out there, and there are little bits and pieces now. But for the most part, everything is some sort of a pressed pill or lookalike that is either fentanyl or methamphetamine. It just whether you're buying Adderall, whether you're buying, it doesn't matter what it is. That it's these 2 drugs. So we're in the process of creating a whole dedicated STEM use disorder groups thing. So for people who actually have isolated STEM use disorder, which is a thing, we're going to help them with that. What we're doing right now, though, is we have them meet with providers as well. So they're getting their group stuff with Suboxone, they're meeting with counselors, doing OUD things, and then they're meeting with providers. And what we're using, there are a lot of meds. There's no silver bullet like there's with opioids. With opioids, you got methadone, you got bupe. They do their jobs. With stimulants, it's tricky. There are some places using long-acting Adderall, which is actually has some pretty okay data. Right now, we're using primarily, and I guess I'll speak for myself. I use a lot of bupropion, Wellbutrin, and topiramate or Topamax. I think it's a great combo, and so my personal practice is so Wellbutrin, as max dose is like 450. I'll start them on 300. If they're not at goal in a month, I'll bump them up to 450. And on that first day, I start titrating up Topamax because the Topamax, the tricky thing about Topamax is it helps with cravings. It helps with that dopamine deficit, but it doesn't reproduce that stimulant effect. I know some people use atomoxetine. Folks were using baclofen for a while. I don't actually think that add-on that's very good. I never use that. But I think in general, we do pretty well with those. And so what they do is they do their group stuff and then they do this other stuff with me. And a lot of it, honestly, 35% conservatively of people with methamphetamine use disorder have untreated ADHD. They just do. It's just, it's an untreated mental illness. This is the idea that, all right, we're not taking drugs to escape. We're taking drugs to arrive. We're trying to treat ourselves. And that's how a lot of it starts. Methamphetamine it's great for ADHD, except for that other thing. That other thing is pretty bad. But it does, sort of do that for a while. And so, you know, honestly, a lot of folks, I'm not treating methamphetamine disorder with ADHD meds, but I am diagnosing and treating ADHD because a lot of people are afraid to do it. And it turns out when you treat ADHD in somebody with stimulant use disorder and somebody with OUD, it often drives down use. And so that ends up being that gateway. So I think ADHD, if it's untreated, treat it. And Wellbutrin, topiramate, I think are great adjuncts. And there are a few more we can talk about at some point, but that's what I do.
And I would just add, thank you, John. I think one of the things that you mentioned resonated with what we're doing is we're really focused on, upfront, individualized, comprehensive assessments to determine what is really going on for this person. And you mentioned, untreated ADHD, really sort of looking at what is this person presenting with in terms of symptoms and how are we targeting this to best support them. And so we really focus on that initial comprehensive assessment to look at diagnosis and make sure that nothing has been missed for this person previously. And then, coordinating with the other members of the team to ensure that they have wraparound supports. If we find that we cannot serve them safely in the virtual setting for whatever reason, we will coordinate with other partners. So I'd love to chat with you all about ways in which we can partner in the future. But yeah, we're really focused on that, providing an accurate diagnosis, making sure that access to care is there in a timely fashion, and making sure that people are, our providers are really focused on non-stimulant medications as the first line of defense, exploring options before getting there, and really supporting, listening to the client in terms of what their needs are and how do we, put them in the driver's seat of their journey.
Yeah. And I love that you mentioned like that, figuring out what's actually wrong. Because again, you have somebody with meth, you say, how do we get you off? How do we get you off meth? How do we get you off meth? The real question is, why are you taking meth, right? Like, are you taking it because, you're worried about getting assaulted or having your stuff stolen at night because you're living in an encampment? Because in that case, using meth to stay awake all night might be the best option for you. And we need to address that first. And so I love the idea that you're going for like root cause, because the drug thing is easy to say, oh, that's the problem because drugs are dirty.
Right.
But oftentimes, like, it's not the problem. The problem is something far further down the line, and you got to explore it.
Yeah, for sure. I think part of our assessment process looks at those things like the social determinants of health. And so really understanding the full picture of the person and what might be some areas that we can provide additional support and connection in their own community that might mitigate some of the reasons that these things are going on.
Well, and this is where my non-clinical background would really show through, you guys. And so for the sake of not embarrassing myself and my medical team, I will only address Sarah's question with yes, we do work with individuals and stimulants and benzos. There's no substance that we don't work with. And next time we'll get our medical director on, he can answer these questions for you guys. But John and Jill, you did a fabulous job. I'm sure they would have just said ditto.
And there was a chat question that asked about replacing stimulants with benzos. How are you all equipped to handle patients with that?
Oh, with benzo use disorder. Yeah. Sorry, I was thinking treating stimulant use disorder with benzos, and I was like, oh no, don't do that. Yeah, so we do that. We do benzo use disorder. It's a little tricky. Obviously, benzos are similar to alcohol. They're opioids. You feel like you're going to die when you're in withdrawal. Benzos, you might actually die. And so that's tricky, especially in a telehealth setting. What we do is we do it for low risk folks. If you have a seizure disorder, and you're on benzos, then you're probably not going to be able to handle that. We don't start anyone on benzos for anxiety. We don't say, oh, you're anxious, let's give you some Xanax. I think that's just not the right way to do it. But we do understand, like, benzos are very much a thing. They're lower on the list, but they're for real. And so the way we do it is we would see what you're on. We would typically, let's say, so we just did this with somebody the other day. on a ton of Xanax from, one of these old psychiatrists who loses his license for prescribing a ton of Xanax. Converting them to something long acting, such as diazepam is kind of my favorite because it's so lipophilic. And do a taper, do a long-term taper. And so that's typically 3 to 6 months. We'll do it up to a year. We don't do it after that. And there are people, right, who genuinely have, these paroxysmal panic disorder things. They need a benzo a couple times a month. We'll bridge you, like we won't do that long term, but we'll bridge you for like a year. If you truly need that. I think that person is very rare. I think the most part is we're looking for these long tapers, and that's really where the data is with most substances, where you're slowly decreasing it. I think the day detox has its place for sure. But the days of like really suffering through that, I think, are gone because you don't have time for the brain to heal, for those new connections to be made. And the same is true for benzos. So we typically put them on a safer benzo. We kind of put them on a long-term taper trajectory to give their brain time to heal itself. And from the beginning and throughout the course, we figure out why are they taking benzos, and we work at that. And so a lot of times, as that gets lowered, there are things they're actually treating that emerge. And so I personally, I really like using beta blockers for these folks. I think especially panic disorder, that can be really helpful. There's a long-acting propranolol now, which is helpful. It makes a lot of people sleepy. I use off-label metoprolol quite a lot because, again, it disrupts that, that cycle of, the anxious thoughts, the adrenaline, the rapid heartbeat, the anxious thoughts, and it sort of creates a buffer there. So I use a lot of benzos. There are a lot of ways to do it, but we definitely do it. Yeah.
I can jump in. We are about 2.5 minutes from our scheduled time, and I'd like to have Danny just kind of bring us home with some closing announcements. Thank you so much. This is our first time out with an hour-long presentation, 3 presenters. It was very tight, but I so appreciate both our presenters and our participants. And Danny, I'll hand the time back to you to bring us home.
Thank you, Dan. Yes, and as we wrap up today's COP, would like to thank all of the participants and also those that proposed the questions there in the chat as they enrich the conversation. Before we sign off, I want to remind you that our next meeting is scheduled for October 17th at noon. We hope to see you there. In the meantime, please visit the nhtac.org website. This is where you can find the resources we discussed today and a lot more, including the slide deck that was shared today. You can also access recordings of previous sessions, view our upcoming schedule, and sign up for future COP events. Additionally, we invite you all to fill our evaluation form that we have. So if you can scan the QR. If you're not able to do so, I'm also putting the link in chat. We really appreciate your feedback, as it is incredibly valuable to make these sessions as useful as possible for you. A big thank you to all the presenters for sharing all the information that you had for us today. Thank you to each for participating. We look forward to seeing you again on October 17th. Enjoy the rest of your day.